Dr. Mary DiBartolo, Associate Professor of Nursing at Salisbury University and host of Focus on Health, a series of educational programs highlighting current health issues sponsored by the Department of Nursing at Salisbury University. My guest today is Dr. John Meadows, who is a gastroenterologist in private practice here in Salisbury. And our topic today is a very important one. We're going to talk about colonoscopy, both the screening colonoscopy and for colon cancer and other reasons that it's done. And you're actually going to take us into the procedure suite to view an actual colonoscopy procedure. So first, thanks for being here today and for doing that for us.
Thank you, Mary.
And I guess the first thing we should talk about is why a screening colonoscopy. We know colon cancer is a very prevalent type cancer. What are the numbers on that?
Well, colonoscopy is certainly a way to screen patients for a polyp. A polyp is just a growth from the lining of the colon, and some polyps develop into colon cancer with time. Not all polyps do that, but we're wanting to find the polyps in the colon and remove them so that they can't develop into cancer at a later date. We sort of use 50 to 55 as an age for screening patients, unless there's some special reason because of other diseases or family history that we would start screening earlier. So all patients, male and female, between the ages of 50 and 55 should have a diagnostic colonoscopy. And it depends on what we find at that time, how frequent they need it repeated. It could be as frequent as 2 to 3 years or as infrequent as 10 years if we don't find any polyps or any risk factors at the time of that colonoscopy. People that are about 50 years of age have a 30% chance of having a polyp. 60 years of age, it's 50%. 70 years of age, it's 65%. Lesions that develop from the polyp to the colon cancer, if you present with a colon cancer right away, you have a 50% chance of being cured at that point. Where at the polyp stage, it's 100%. And so that's the main emphasis of trying to screen patients.
Well, that's with most of the cases of cancer, early detection.
Correct, that's the whole key.
What would be some symptoms that someone might have where they would come to your office and you would say, let's do a colonoscopy? And we're in outside of the cases of people that just turn 50 or whatever and come in for the screening.
Right. Well, of course, patients that have polyps usually have no symptoms at all. But rectal bleeding, and especially what we call occult bleeding, means that we don't really see blood, but we do hemoccult testing of the stool and find that there is blood in the stool, even though the patient doesn't see it. And those patients, especially if it's associated with iron deficiency anemia, certainly need colonoscopy on the basis of that. There's always a reason why there's blood in the stool, and it's always abnormal.
Well, sometimes blood in the stool can be from hemorrhoids, correct?
Usually people will know that they're bleeding from hemorrhoids because they'll see the blood. It'll be on the toilet paper, or they'll know it. The occult blood means they're not seeing the blood. Family histories, some families certainly have a high prevalence of polyps in the family, sometimes as many as 1,000 polyps in any one colon. And those patients and family members of patients need to be screened at an earlier age.
And that's called familial
Correct.
polyposis?
Right. There are several syndromes like that. Gardner disease is another one. People that have inflammatory bowel disease like Crohn's and ulcerative colitis need to be screened and at an earlier age because there's a higher incidence of colon cancer in inflammatory bowel disease patients. People that have had change in bowel habits without any particular reason, especially if they're older patients, need colonoscopy. Patients who have abdominal pain of unknown etiology, it's another group that we certainly look at. A lot of these patients have a disease called diverticulosis. Patients who present with a complication of diverticulosis, which is diverticulitis, that's actually a little hole that develops in one of these little pouches and walls itself off, and that's called diverticulitis.
And that's actually an inflammation.
Inflammation, correct. And after patients are sort of over that episode of pain and an inflammation, then they need colonoscopy to sort of evaluate the extent of the disease and whether something needs to really be done about it other than just following the patient.
How common is diverticular disease?
It's very common. All patients eventually develop some diverticuli. It's just the weak spot in the bowel where blood vessels come in from the outside. So it's present in all patients as we get older. But the thickening associated with that, of the wall itself, and the number of diverticuli is the key to disease versus just a normal aging colon.
Now, how common is colon cancer?
The total life experience in colon cancer in a lifetime is 6%.
I know it's one of the ones that many people are most frightened of because you do hear a lot about it. You hear about younger people dying from colorectal cancer.
It's fourth most common cancer, and the second for morbidity.
And I know that's one of the reasons we want to get the word out about the importance of the screening colonoscopy, because if it's caught early, particularly at the polyp stage, it can save lives.
Absolutely. In fact, what we tell patients is that when you look at screening procedures in general, the cost effectiveness of screening procedures and life years saved, colonoscopy comes out to be second of all screening procedures, second to blood pressure checking.
Now, let's just talk about what exactly a colonoscopy is. An oscopy meaning putting a scope into the colon, and I know you wanted to talk about it from a timeline perspective, from when a patient comes into your office, what exactly transpires before they have the procedure done.
Right. Now, a patient gets referred to our office specifically, usually for screening at that juncture. And we tell the patients that we're going to schedule this at the hospital, and we tell them that they have to take a prep. Prep means to clean the colon out, and we basically have 3 ways to do that. One is a large volume prep that we call Go Lightly. That's a prep that's been around a long time. It's 2 to 3 liters of fluid that you drink over a period of time to sort of flush out the colon.
A few days before you start doing that?
Usually do it the day before or the day of if it's an afternoon case. So it depends on when the procedure is scheduled for. The second prep is actually an enema that we drink, and it's an over-the-counter preparation, Fleet's phosphosoda. It's about 1.5 ounces, followed by some ginger ale and several glasses of water, 2 doses of that spread out over a period of time. That's the most common prep today. The third one is actually a pill. We call Osmo now is the name of this pill, and it's very much related to the Fleet's phosphosoda, but it's a bunch of pills that you take, again, spread out over a period of time, just pills and water. But the pills are pretty good size, but they're wax coated, so they're easy to swallow. The disadvantage of that is it's a prescription and it's more expensive. But most insurance companies that have drug plans will cover that. And in general, colonoscopy is covered by virtually all insurance plans, Medicare as well.
And when does a person have to stop eating and start the fasting process?
Well, actually, we put them on a clear liquid. Usually the day before, we have them on a clear liquid. The day of the procedure, we usually tell them not to be taking anything to eat within 4 to 6 hours of the procedure. It depends on their medication. Sometimes allow them to take the medication. We adjust insulin levels, blood levels for insulin. So it's 4 to 6 hours before the procedure is the average time if they're going to be sedated.
Okay, well, I guess give us a brief overview of what we're about to see.
Okay. We have a patient who came in for a screening colonoscopy, and we explained the prep. We told the patient that they would have to come to the outpatient part of the hospital where we'd start an IV and give them some medication. It makes them very, very sleepy, sort of called conscious sedation. It sort of blocks your memory for the procedure. It's not a general anesthesia. You're breathing on your own. You're actually awake, but you don't remember you're awake. It's a sort of a strange feeling when the procedure's over and they don't remember they had the procedure done, but yet they were awake for the whole thing.
And that's used for a lot of various procedures,
things, right.
yeah.
And we take them to the endoscopy center, which is on the second floor of Peninsula Regional Medical Center. It's over top of the emergency room. That's all it's done on that area of the hospital or GI procedures. We usually have 2 nurses in the room, one to help me with the patient and one to sort of circulate around the room. And we tell the patients about a 30-minute procedure average. And if we see any little growths, polyps in there, we take those out. That's totally painless. The colon can only sense pain by stretching it. You don't sense pain by any cutting that you do inside the colon because the nerve fibers are only in the circular muscle wall of the colon. So it's only the stretch that gives you any sort of pain in the colon. And we sedate patients. Most of the time we sedate patients because they're just anxious, not because it's a particularly painful procedure. Some patients actually elect not to have any sedation at all so that they can drive themselves home and they don't have anybody to drive them.
But the majority take the
sedation,
I take it. Yeah.
Right.
Okay, well then how about we'll go into the endoscopy center at PRMC and take a look at a colonoscopy.
All right. This is a colonoscope, and this one is a video scope. We used to use fiber optic scopes, and now we're all with chips, and we're going to be able to view this on TV screens here as we pass this instrument into her colon, which is about 5 feet long. Now I'm going to what we call retroflex first in the rectum, which means, back up a little bit, we're going to sort of flip the scope around to look at the hemorrhoidal area, the internal hemorrhoidal area. Back up a little bit.
Okay.
Which looks very good. I don't see any significant internal hemorrhoids here. And the black you see there is the scope that we're sort of turned back around on the scope looking at it from the inside. Now we're advancing into the sigmoid colon, which is the first turn on our way up the left side of our colon. We're putting air in as we go along here, which will, normally the colon is flat, and we put the air in so we can see the lumen to pass the scope. We're in the upper sigmoid colon at this point. We'll really be able to look at this much better on the way out. We actually do our investigations as we remove the scope. The goal at this point is just to get the scope to pass all the way through the colon.
Uncomfortable there?
Entering the left colon, the descending colon.
How you doing, man? A little better? Pain better?
Sometimes it helps if they are able to pass a little of the air that I'm putting in. So it's not any gas they're producing. I'm actually putting this air in the colon. This scope has the ability to become a little stiffer, so once I get past the rectum, I usually can stiffen the scope a little. It's easier to pass when it's a little stiffer. Now we're sort of retroflexed here, so you can see the scope again. That mark on the scope is just 20 centimeters, so we're retroflexed around looking back at ourselves. Push on the right lower quadrant for me just a little bit so we can see that sort of another way to check the location. Okay, we're coming back now. I'm going to loosen up the scope a little bit, make it more flexible. A little residual stool still present, and we're in the cecum now, the right side of the colon, and appendiceal defect. We'll see if we can show that a little bit better, where the opening to the appendix would be. Whether you've had your appendix taken out or not, you still have an opening from the colon, from the cecum into that area. Which is right there, right in the center of the screen. A little dimple-like. And we do our looking coming out. And we sort of come back slowly and take the air out a little bit as we come, looking for polyps, little growths from the lining of the colon, which is what we're really after. If this patient does not have any polyps, no risk factors, and she probably doesn't need another exam for 10 years. Depending on how many colon polyps she has and what the pathologist tells us the consistency of these polyps are determines when we do another exam on her. Now we're in the ascending colon. It's on the right side of your abdomen. The blood vessels are pretty visible here, the little red blood vessels. Very normal looking mucosa at the present time. Some more liquid I'm going to try to get out of here. Prep is pretty good. And coming up to what we call the hepatic flexure. It's called that because this is sort of where the liver pushes down on the colon. And we're making a turn now into the transverse colon. Comes across the top part of the abdomen. Good blood vessels here. So far we haven't seen any evidence of any polyps. Just took a picture. Come on back. Going to ask her to push a little more air out.
You may feel full in your abdomen. It just means you need to have gas. Okay? Go right ahead and let the air out. Fine. You're doing great. We're almost done.
Come on back a little bit. That's the air I was putting in there. It's sort of a triangle look at this point with the lumen itself. This triangular look is what we see in the transverse colon. Helps us a little bit with the landmarks. And we're approaching another little turn that we call the splenic flexure. Again, because the spleen pushes down on the colon at this spot. It's a little teeny tiny polyp here that we'll take a little biopsy of. It's that little growth right there. Very small. We use a forceps to go through the scope to take the biopsy. Then we send it to the pathologist. Open. Close. Okay. And that was There'll still be a little residual of the polyp there, but that will slough off because we've sort of disrupted the blood supply with that biopsy when they're real small like that. And that was a very small polyp. Come on back. Now we're in a descending colon, going down the left side of our abdomen. Now we're down into the rectum. And we're coming out. And then we're all done.
Well, we're back from the endoscopy center at PRMC, and there was a few things that struck me about the procedure. First off, how healthy the colon looked. You could see the blood vessels very clearly, very pink and clean.
Yes, this patient had a fairly good prep. The liquid that you saw was part of the prep, but very, very clean colon, and the vascular supply looked very good. You can tell a lot about the blood supply of the colon in disease states, but most healthy colon looks pretty well the same. And it's hard to tell the age of the patient from the colon in a normal, healthy patient. Certainly in a disease state it looks different, but this was a very healthy looking colon.
The other thing I wanted to point out, or that struck me, was you really put the colonoscope in very quickly, and the majority of what you're looking to see is on the way out with the colonoscope. And it is very flexible, isn't it? So that's not really what's causing any discomfort.
No, it's just the air that we use that causes any discomfort. Air is not absorbed by the colon, so it actually, we use the air to dilate the colon so we can see, and then we remove the air as we come out, or the patient passes the air that we're putting in there.
And that's a good thing, because I know we heard a lot of some air escaping during the procedure.
Right, we just put more air in when it does so that we can see. The main purpose in putting the scope in is to get to the end of the colon, about 6 to 7 feet of the colon. So our purpose is to get to the end of it, and then we look for pathology as we bring the colonoscope out. It sort of produces an accordion effect when you go in with the scope, so we're straightening it out a little bit as we come back and removing the air at the same time.
And of course, in this case, you did have the opportunity to remove a polyp that you saw.
Correct. The patient had a small polyp, about 8 millimeter polyp, and we removed it with a biopsy forceps. There are two ways to take a polyp out. One is with a forceps, and the other one is to put actually a snare, a wire around it, and use electrical current to coagulate the vessel inside the polyp, and then to cut through the polyp and remove it through the scope. This particular polyp turned out to be a benign polyp. It was what we call a true polyp. It was an adenomatous polyp, and these are the kinds of polyps that could grow into something like a colon cancer, as opposed to a hyperplastic polyp, which is totally inflammatory and has no cancer potential to it.
Now, if someone has that type of polyp, then they would need to come back a little sooner than later for the screening, rescreening, or retesting.
Right. This patient we're going to look at again in 5 years, because there was a polyp. It was a true adenomatous polyp, and we'll re-scope this patient at 5 years. If no lesion had been found at all, we probably would not have looked at this patient again for 10 years. So it depends on the number of polyps, the size of the polyps, the type of polyp it is when you repeat the procedure. It could be as frequent as 2 years or as long as 10.
And let's discuss the recovery. The patient would go from the endoscopy room to a recovery area.
Right, a recovery bed where they're assessed as far as their pain and discomfort is concerned, and how awake are they from the sedation. And once they're sort of awake from the sedation, their IV's taken out, and the patient then is moved to a chair, and they're giving something to drink at that point. We go talk to the patient, and then they're discharged to a family member to drive them home. They leave there in a wheelchair. That's just the policy of the hospital, even though they're awake and talking and walking, and sometimes blood pressure changes still can occur even after they're awake. So we let them go out in a wheelchair, and hopefully they go home from that point.
And they can go back to their regular activities
The next day.
The next day.
Right.
So really it's just the day before or so they're doing the prep,
Right.
the day of, and then the next day they're back to their normal activity.
Correct.
And you're saying some patients will have some discomfort, but that is strictly from the air from
That's
the
right.
colon being
Right.
distended.
If they've sort of decompressed all the air there in the endoscopy center, they'll have no discomfort at home. In fact, that's what we watch for, is any increased discomfort or bleeding at home, and they're given specific instructions to call if any of that occurs.
And there's nothing they can really do about it except to let it pass, per se.
Right.
Now, one question about this is, do most insurance companies cover this procedure, particularly if it's a screening
Yes,
type?
in Maryland, all insurance companies cover a screening colonoscopy procedure, including Medicare.
Well, it sounds like it is something we need to emphasize. It's very important because of catching anything, any abnormal findings early on. Now, one thing I did want to ask you about, and it's gotten some press of late, and I don't know how commonly it's done, is the whole concept of the virtual colonoscopy.
Well, there's been a big effort in the past to find some alternative to colonoscopy. And virtual colonoscopy is basically a type of X-ray that allows the colon to sort of be looked at in a screening fashion. The problem with it, of course, is one, it's X-ray, it's radiation, and two, if a lesion is found or a polyp or something's found, you still have to have the colonoscopy done to remove it. But it may have a role in screening mass patients, in a large number of patients. Recently, we have a new technology, which is the PillCam colon, which has been released, and that's
It's a camera, per se.
It's actually a camera that you swallow. We have them for the esophagus and the small bowel, and now we're going to have it for the colon. So basically, you swallow this capsule, and it takes pictures of the colon in its natural state, without air being inserted, or without any sedation to change the blood supply of the colon. You do have to be prepped for it. The difference between that and the small bowel or esophageal pill cams. You do have to be prepped for it. But again, if a lesion's found, you still have to have the colonoscopy.
You still have to have the colonoscopy,
Right.
so it seems to make sense that people still continue to do that. Because you, I believe you said you can also take care of things like hemorrhoids, internal hemorrhoids, while you're doing the colonoscopy, polyp removal.
Right. We tell patients that if they have significant internal hemorrhoids, then we can inject sclerosing agents, which sort of shrink back the internal hemorrhoid, and take care of that at the same time while they're sedated for their colonoscopy.
Well, I still know there's a lot of education to be done about the importance of getting this done when you turn 50, or if you have family history, of course. What do patients tell you is the main reason that they may not want to come in and get this done, the reluctance to get the colonoscopy done?
Probably the most common problem they have with it is fear. I mean, they really fear the procedure. They've heard bad stories about how painful it was, and so they're really very apprehensive about the pain of the procedure. Some patients are apprehensive that we're going to find something, and that they're having no symptoms at all. So why should I have this procedure done? I'm fine. You know, I'm afraid if I have something done like this that you'll find something, or that I'll have some complication from the procedure itself. The risk of any complication from colonoscopy is about 0.4%, and that includes bleeding, drug reactions, and even a hole in the bowel perforation.
Well, the benefits would definitely outweigh the risks then of finding something early and getting it taken care of. Although, let's face it, getting the procedure done, it's a very private thing, a private area, so I know many people are very anxious about that, or don't want to do it for that reason primarily. And also, I know I've talked to some people that have had it done, and they mentioned that the prep really is more problematic than the procedure itself.
Certainly have patients that have had the procedure and will tell us that all the time, that the prep was worse than the procedure. So, because it does obviously produce diarrhea to clean out the colon. But it doesn't produce cramps, so it's just a matter of just having liquids sort of pass. And So it's not like when you're having an acute case of diarrhea. It's a little different than that. But the PrEP certainly can keep you up some at night. I mean, the length of time it takes to pass the PrEP, the solution varies from patient to patient. The privacy issue is of concern to some patients. The endoscopy suites are kept at a real low light level. We sort of use small, what we call minimal lighting, and nurses are in the room at all times. We drape the patients very well, and then they're sedated, so that's all that helps with the anxiety and the privacy issue.
Well, again, let's just reiterate the screening recommendations for people that obviously aren't having bowel symptoms but just need to have the screening done for colon cancer.
Well, all patients between the ages of 50 and 55 should be screened for colorectal disease. Again, looking for the polyp is the main reason for doing the procedure, both males and females. It depends on then what's found, what the recommendation is beyond that. If nothing is found, no polyps, no risk factors, then probably over 10 years is what the recommendation is, especially Medicare at the moment. If there's a strong family history, especially on both sides of the family, then we may look sooner than 10 years.
And when you say family, you mean parent, sibling, both of those?
Right.
If someone's diagnosed with it, then should everyone in the family go ahead and look into getting a first-time one done? It
depends on the age of the family member who has the lesion, if they're polyps or whether it's colon cancer. If it's, say, it's a 70-year-old uncle, it's different than a 30-year-old sib. It's much more important and a stronger family history if the patient is under 50 and especially under 40. That puts a bigger risk in the family. Then you're sort of worrying about whether there's any hereditary sort of predisposition.
And of course, an ounce of prevention. Let's just review some tips for our general public on what they can do to keep their bowels healthy.
Okay. Certainly good physical exercise is important. Diet that's high in fiber, eat your vegetables. Try to stay away from too much red meat. Certainly antioxidants are probably important. Calcium is probably important. The things that are more of a risk factor is the fatty diet. Actually, there's some data even shows that people that have had cholecystectomies may be at more risk for colon cancer. And that's sort of something that's been looked at more recently. People that have pre-existing conditions like inflammatory bowel disease, ulcerative colitis, Crohn's disease.
Let's just mention what a cholecystectomy is. That's removal of their gallbladder, which stores bile, which helps digest fat. So that's why that's a point.
So those are the main things that you can do in your diet. Tobacco, not good for the risk of colon cancer. Alcohol in excessive amount, and weight. Certainly, again, has to do with the fatty diet and all that, but certainly obesity is a higher incidence. There's a higher incidence of colon cancer with obesity.
Well, the good news is fiber seems to be on the upswing again as far as being in the media and what are good sources of fiber, and there's more packaging, bringing that out to the public of what has fiber, what doesn't. So that's good news. Makes it a little easier for us to identify foods that would be good to eat. And of course, fruits and vegetables.
Right.
Well, thank you so much for coming
Mary.
in today and for taking us into the procedure suite to take a look at a colonoscopy. Hopefully this will help our viewers see that it's, understand that it's not as problematic as some may think in their minds. I guess it's the fear of the unknown, and this certainly helps take care of that by letting people see what actually goes on with a colonoscopy.
Thank you, Mary, for letting me share this information with you, and hopefully we can get the word out about colonoscopy and prevention of colon cancer.
And we'll post some websites at the end of the program where people can get more information about colorectal cancer and the procedure itself.
Okay.
And thank you for joining us for this edition of Focus on Health here on PAC 14.